right, everyone, we are going to go ahead and get started with our first CPC of the year. We have Dr. All right, we have Dr. Johnson here. He was sharing with me before that this is his 9th CPC, so
Oh my God.
we are in for a treat. And we have a case today of a 41-year-old female, a history of aflutter, DVT and PE, who's anticoagulated with Xarelto, presenting for hematemesis. We are going to, there are no disclosures, and we're going to talk, just because this is the first CPC of the year, we're going to talk a little bit about the history. So I know many of you have been to these before, but this was a conference that was actually modeled after law cases that were presented in lecture styles at Harvard. And this is George Dock. He was the first chair of medicine who brought it here to WashU. And CPC has been done since the 50s here at WashU in rooms looking a lot like Clopton. So this was the pit, the first auditorium where it was held. And just the thought of getting an expert clinician to share their thoughts and walk through a case. So just a little bit of an intro. This is Dr. Johnson. He is an associate professor for medicine in the Department of Hospital Medicine. He has done a lot of his training in the Midwest and went to undergrad at St. Norbert's College, and then at the University of Wisconsin in Madison for med school, and then he did a residency at Marshfield and then the University of Iowa. So I will turn it over to him and let him introduce himself, and then we will get into the case.
You guys hear me okay? All right. I first want to extend a very sincere and heartfelt thank you for allowing me to kind of kick the ball off for the academic year as far as CPC is concerned. I'm often not here when CPCs are taking place, but like I might have watched them at home or similar. So that's holds also true for any folks that are watching this remotely. I was going through and looking at the getting my slides prepared and realized I was actually here last year at almost exactly the same time. So again, I want to say thank you for re-inviting me back. Next slide. So the first thing I want to say is that I tried really hard to be able to come up with something that would ultimately unify this presentation. And I could not, which is great. So I think one major thing that I want to say about CPC in general is that it's not about getting the answer right. It's about trying to think about how things might be related and put things in the context of the individual patient based upon information that you're gathering. So if we can go back to the slide that I had. So to me, nothing popped up in that one-liner that immediately says, oh, this is what it is, okay? So one thing that I want to stress, and for any of those, any people who are watching who want to come up here and do this, one thing I suggest is looking at New England Journal's clinical problem-solving vignettes. So the CPCs are good too, but they're usually kind of arcane. These, although this was kind of an arcane case too, but that's beside the point. These cases kind of showcase how the discussant thinks about a case. So things that come up in a logical fashion, and then if there are, forks in the road, or maybe, you do a 180, because we do that in medicine. So whenever we have cases in front of us that are challenging, sometimes you have to step back and say, maybe I wasn't thinking about it properly. And I think this does a good job showing that. So I will try to do something very similar with this case. So there were a couple things that I wanted to say about the one-liner, just in general, that I will want to kind of flesh out in more detail. So first of all, you look at this and you say, oh, hematemesis, well, it's got to be the Xarelto, right? Okay, we have tons of patients who are on DOACs, who are on warfarin, they're therapeutic, and they don't present with hematemesis. So first thing I think about whether or not someone is anticoagulated is there some sort of mucosal or vascular lesion that's resulting in blood coming out, okay? So item number 1. 2, is it truly hematemesis? In other words, if someone is bleeding heavily, is it actually from their upper airway? Is it from their nose? I had a patient, this was quite a long time ago, of course, during my training, but when I was in the ICU, who had a Swan-Ganz catheter in, and by virtue of that, developed lung hemorrhage, which is very devastating. And It looked exactly the same as any patients that I've seen with variceal hemorrhage.
Mhm.
So because they're bleeding out. So I would not automatically assume that it's coming from the esophagus or the stomach, but I would think about that potentially, although I would say it's pretty likely. Thirdly, the other oddball thing is that typically when we're dealing with fib flutter, it's typically a phenomenon associated with cardiopulmonary disease. So you'll see many patients who have, things like heart failure, reduced EF, or, lung disease, maybe they have pulmonary hypertension, not to mention hyperthyroidism. There's typically something underpinning. Lone AFib flutter is not that common. So it's just a little odd to me that this is a 41-year-old who has this presentation. So that's also something we're going to want to delve into. Does this patient have a prior diagnosis of cardiac history or a lung history, some sort of pulmonary disease? Or do they not, and it needs further workup? So that'll be important to this case as well, I think. Now we're assuming that those two things are related, but that's the information we have. So that's all we can go by.
Yeah, those are some great pickups already on not a lot of information. So I'll go ahead and give you a little bit more about what's going on with this patient. So she started having 1 day of nausea and then subsequently had 6 episodes of bloody emesis. She describes it as throwing up blood with some clots in it. Subsequently, she had a few episodes of lightheadedness where she would try to stand up and become unsteady, and then they would improve with rest. Prior to this, she was in her normal baseline state of health, going about her day-to-day without problem. She has been compliant with the Xarelto that she's been taking. She's been on that for several years without change. She denies any hematemesis, any melena. She has had some darker stools and she's on oral iron supplementation, and the darker stools have been present since she started taking that. She does have some menorrhagia, but no other bleeding or bruising, and she's never had episodes of bleeding like this. There's no family history of bleeding that she's aware of either. All right, and then just a little bit more about her past medical history. So kind of as you mentioned, she has had a DVT and PE. It was actually a large clot burden PE back in 2017, and that's when the aflutter was diagnosed. And then she subsequently actually developed some pulmonary hypertension that was thought to be due to CTEPH. She started to be anticoagulated, and her pulmonary hypertension actually improved with the improvement of the clot burden. She did get a thrombectomy as well. She has had an intermittent aflutter and this large clot burden with the DVT PE, so that's why she's remained on anticoagulation. And in her procoagulable workup, they did find her to have a prothrombin gene mutation. She also has some anemia and hypertension that she takes some medications for. Her family history, some hypertension, heart failure, lung cancer in her mother, nothing too remarkable there. And then she's on some medications for her blood pressure, metoprolol for her flutter, and then the Xarelto, iron, and a statin. And she's never smoker, no drug use or alcohol. Any thoughts or other things that you would like to know at this point?
Okay. So she's only had one event, as far as DVT PE is concerned, right? So no recurrent events, no prior history of clots, but she clearly has chronic sequelae related to thromboembolism, which again might fit with our atrial flutter history. So that kind of fits nicely. We don't have any family history of recurrent thromboses that I see, and medications. Not a lot of clues there. I don't see any weird interactions. I don't see anything that should set this off. So not a lot to go on yet.
All right. We have a review of systems that's also not extremely helpful. So I just wanted to ask you at this point. So we have a younger patient who has now 6 episodes of throwing up blood clots. Do you have any, I was wondering if you could just kind of talk us through how you're thinking about assessing the stability of this patient or initial management as you're seeing them.
Okay. First order of business is to verify how the patient's doing from a hemodynamic standpoint, right? So going into these cases, again, usually you're thinking the source is from the gastrointestinal tract. It's very clearly hematemesis, so it's upper GI. So you're starting to treat by making sure you can stabilize the patient first, because none of this is any good as far as working it up if the patient dies. So, making sure you have intravenous access, making sure you've got blood types crossed, making sure you've checked their hemoglobin stat, things like this. I'm thinking about, consideration of endoscopy, but before we get there, we have to make sure that they can get this patient to the endoscopy suite.
Absolutely. And how do you think about her Xarelto, if at all?
So this patient has bleeding that potentially is going to get you into trouble. So you have to make decisions about, do you have a reversal agent, and do you use it in this case?
Okay, absolutely. Thank you for walking through that. So we'll go ahead and get some vital signs in the physical exam. Her blood pressure is stable, heart rate in the 50s, but otherwise saturating well on room air, looks pretty comfortable.
And she has beta block for what that's worth, so we'll keep it in the back of our mind.
Absolutely. And otherwise the exam is not too remarkable.
Okay. So I'm looking for things that are pertinent as far as positives and negatives to make sure we're not missing any obvious things. So not seeing any evidence of any kind of tendency towards bleeding elsewhere, no purpuric lesions, no ecchymoses. You appropriately mentioned any stigmata of hepatic disease, which is fair to think about if you have someone who you're presuming has an upper gastrointestinal source of bleeding, lest they have variceal hemorrhage. Although we have to keep in mind that cirrhosis is not the sole cause of varices, right? So you have the entity of non-cirrhotic portal hypertension. So it's something we need to kind of keep in the back of our mind, talking about the possibility of lesions driving this. But yeah, so.
Absolutely. Okay. So we'll go ahead and get some initial labs. So we have a chemistry here showing a little bit of an acidosis and an AKI. Baseline creatinine prior to this was 0.7 on presentation 1.5. Otherwise, an elevated alk phos to the 400s. And then otherwise pretty unremarkable. Also get you a CBC here. So has an anemia with a hemoglobin of 10.7. Otherwise normal platelets and a normal diff on this.
And a normal MCV as well, with relevance to the iron administration. So.
Okay.
So as far as my personal thoughts in this regard, looking through it, I see the bicarbonate is slightly low, just off the cuff, figuring out her anion gap. Okay, looks fine. So hopefully the math works well up here on stage.
It's normal.
Always making sure. Creatinine's mildly elevated. Not too exciting, but a pretty high alkaline phosphatase. However, we don't see any obvious abnormalities in hepatic function that will automatically tell you that the alk phos is hepatic in origin. So we'll keep that in the back of our mind as far as, next steps. And again, see if this necessarily relates to your presentation.
Okay. So now it is a choose your own adventure as far as where we're going to go with diagnostic workup. I heard you mention endoscopy, other things that you're thinking right off the bat that you want to pursue.
Okay. I think it would be very helpful in this case. We already have our CBC. So I think that is useful for us for initial triage and management. Because this patient is bleeding and because we need to know exactly how we're going to manage that, probably not a bad idea to think about coagulation parameters. So getting coags may not be a bad idea right now, since it's kind of to use a George Doc's example, that's where the money is, right?
Right. So coags it is. So we have some abnormalities here. We have an elevated PT-INR and a PTT that is elevated. Also got a fibrinogen A D dimer and then an elevated anti-10A.
Okay.
Would you mind walking us through what you're thinking about these coags?
Okay, this is going to be harkening way back to my past in terms of thinking about coagulation cascade. But you can see both the PTT and the PTT are quite elevated. So, and the INR is going to be a reflection of PT. But basically, if we're talking about management with, if you're talking about warfarin, for example, that would predominantly affect PT, we usually don't use these parameters to follow anticoagulation with the DOACs. But for what it's worth, if we're talking about rivaroxaban,
Mhm.
which we were given earlier, that is going to act on factor 10. And if I recall correctly, I think that's at the crossroads. So, like I said, old information, I kind of rusty. I
Yeah, the coagulation.
got dusted off a
needed.
little bit. Fibrinogen looks fine. D-dimer, again, might not be the most helpful. Anti-10A can be useful in this context, and that's elevated.
Right.
So the question is going to become, does this relate directly to administration of what she says she's been compliant and not taking extra dosing, or is there something else afoot here?
Absolutely. Yeah, I think those are great points. And she says she hasn't taken any extra or any doses, but also thinking about that at this point. As follow-up testing of these coags, is there anything that you would want to get to kind of further elucidate what might be going on?
Fair to think about. So, obviously in a patient like this, your first order of business is to correct this, right?
Yeah.
Lest they continue to bleed. So, thinking about factor concentrates will likely be, important part of things.
Mm-hmm.
I'm just thinking offhand as far as other things. The other thing to think about, of course, is if you're dealing with inhibitors of, medication inhibitors, that's one thing.
Mm-hmm.
And maybe I shouldn't use the term inhibitor because that has its own meaning separately, just so I don't confound things. But if you're dealing with a deficiency state of one factor or another,
Mm-hmm.
you can do a mixing study and look to see, does that fix it? Versus, thinking about, the factor inhibitor that we were talking about, which is an antibody,
Mm-hmm.
which does
yeah.
respond as well.
Absolutely. And the next thing they did in this case was to get a mixing study to see if it was a deficiency or an inhibitor. And her coags corrected with the mixing study.
Okay. So if coags are correcting with your mixing study, I'm just looking through it just to make sure. If things are correcting properly, that indicates that it is a deficiency state and not driven by a factor, an antibody being a factor inhibitor.
Yeah, absolutely. So you would think that they would remain prolonged if it was an inhibitor. And in this case, because they corrected, the next step was to actually get a factor assay. So here we go with a factor assay, most notably for a markedly low factor 10 level.
Okay. So that is very interesting in that, as I mentioned earlier, rivaroxaban is going to act on factor 10. The remainder of it, one nice thing about the coagulation cascade is the redundancy built into it naturally, right? So we've had this around for, God, I have to think back to when this arose in development of animals in general. But, the good news is we have enough other factors that are there, but we only see deficiency in the 10.
Mm-hmm. Okay.
So the question becomes why?
The question is why, and we will try to get to that. So, like you were talking about, she got vitamin K and FFP while working her up for what was going on in terms of the coagulopathy, stabilizing her. She was stable to the point of not having any more episodes of bleeding, remained hemodynamically stable. So GI said, all right, at this point, we'll do an endoscopy.
Okay, which would have been, my next selection. So,
yeah. All right, so we will go ahead and get the endoscopy. They found a large blood clot in the gastric body. They decided not to remove it because of her continued coagulopathy and so super therapeutic INR. But they did notice that the gastric mucosa was erythematous and friable. And even minimal contact with the water jet they were using caused oozing throughout the stomach. And there was some friability in the duodenal bulb as well. Does this information help you at all?
I think it gives us a sense for where this might be emerging from, although I agree with GI's management in terms of avoiding removal of said clot. It's very interesting that they found abnormal areas in the gastric mucosa. I mentioned earlier the prospect of non-cirrhotic portal hypertension. So thinking about PHD or portal hypertensive gastropathy, you could see something very similar with that. So maybe that had augmented her bleed. Doesn't help you explain why the factor 10 level is so low, though. I find that a little bit odd. So I don't know that I want to necessarily go So that is the cause. Was this the entire gastric mucosa or was this localizable? Were there regions that were involved?
It was relatively diffuse throughout the mucosa, but there were some areas that were more friable than others.
Okay. Because that might make you tend to think about, is this involvement due to PHG versus maybe some sort of infiltrative process?
Yeah. And I think you really aptly pointed out that we have a woman with a coagulopathy and a factor 10 deficiency who's bleeding, but something is going on in the gastric mucosa that's causing her to bleed. And so kind of trying to piece together those things and figure out what's causing her deficiency.
I don't know if you noticed my facial expression during this time, but there is a condition that can result, it's an infiltrative process that can result in binding to factor 10 and kind of take it out of circulation, as it were. That could probably add to things.
Okay.
So just something I'm thinking about in the back of my mind.
Yeah, absolutely. Well, also a piece of information. So when she was in the ED, she came in, they said, she has an AKI. We might as well get some urine on her. So they went ahead and sent urine studies, which I'll put up here.
Whoa.
What is that reaction from?
Speaking of.
Yeah.
So very interesting. So looking at the UA, so spec grav is quite low, unremarkable pH. On the urine dipstick, 2+ protein, a little bit odd. Hard to tell what to make of that all by itself in a patient when you're getting it just out of the blue. We don't have any history of such. But boy, that's a lot of protein to be spilling on a spot. Now we got to be careful with it. I was just telling my team past couple of days on firm that this is a 24-hour collection, right? Not a spot.
So it was a spot is the first one, and then they followed it up with a 24-hour urine.
Just making sure.
Yes,
just
absolutely.
The spot is going to tend to be less helpful with an AKI, just because you're assuming that creatinine clearance for the entire 24-hour period is a gram, so you can compare the two. Okay. So obviously that's going to be remiss when you have a kidney injury. However, the 24 hours legit. So this is an awful lot of protein. Okay. And that's all we have really out of the ordinary. We don't have any, the white cells are normal, red cells are normal. No one's mentioned anything about red cell casts, white cell casts. So highly interesting.
Does this point you towards any specific processes that might be happening in the kidney?
One that I'm thinking about in the back of my mind, yes.
Do you want to clue them into what you may be thinking about?
All right. So I don't know that this patient has a specific condition that would predispose to the condition that I'm thinking about. I don't know that we necessarily have to wait that long because it doesn't always become that obvious. And sometimes chronic states can result in this of varying cause. Okay. But really what I'm thinking of that could unite the two, that could definitely result in proteinuria to this degree, plus result in gastrointestinal lesions, plus result in binding to factor 10 would be amyloidosis.
Okay.
So I would worry potentially about renal involvement related to this, along with gastrointestinal involvement presenting as GI bleeding, plus what we're seeing.
Absolutely. Okay, so that's a great thought. And so we're kind of in the nephrotic range proteinuria here. What would be your next steps in working up potentially amyloidosis and just the proteinuria that we're seeing?
The gold standard at this point, if you wanted to make the diagnosis up front, you're going to need a piece of kidney. Okay, so it's an involved organ that, clearly is impaired. You're not going to be thinking about that until you've stabilized this patient.
Absolutely.
So that's going to be something that we'll have to kind of push a little bit down the road. However, the gut's also involved. So you could also get a snippet of tissue there to see. And then it's a matter of trying to figure out assuming that this is amyloidosis, indeed, what the abnormal protein is.
Absolutely.
So
the team is asking for biopsies and everyone's saying her INR is still 3. We are not touching it yet. Are there any lab tests that we can send or other urine tests that would be helpful?
They would not do a fat pad biopsy?
Not at this point.
With an INR of 3?
Not at this point.
All right. Let's entertain ourselves with more labs then.
Maybe just because this is CPC.
Okay, fair enough. Let's see. Just because we haven't, and this is actually a fair point, just because we haven't necessarily found the context of how this patient might have amyloidosis in this case, let's see if there's anything underpinning that would help to drive that. So we can look at rheum and immunology both to try to sort that out. So if you want to start with rheum.
Sure, let's start with some room studies, serologies. So.
Not very exciting.
Okay.
Okay.
Also, as part of the nephrotic range proteinuria workup, they got in some infectious studies with an HIV, RPR, hepatitis that came back negative as well.
Never a wrong answer. While we're on that topic, thinking about these types of things too, in someone with nephrotic range proteinuria, thinking about underlying malignancy, thinking about subtyping it further, again, because we can't get a renal biopsy, thinking about, does this fit in a certain category? Again, minimal change disease, relatively uncommon, but we think about membranous nephropathy. It doesn't have some of the other hallmarks that would suggest things like NPGN, which again is going to be more of a nephritic pattern. So this looks more nephrotic, and then FSGS. So that's kind of how I would kind of structure it. So this is all really appropriate.
Absolutely, thank you. All right, and some immunology. So this is where they got the SPEP, UPEP, immunofixation, and the free light chains. And we see here that we have an elevated kappa and an elevated kappa to lambda ratio, as well as a free kappa light chain paraprotein spike on immunofixation.
Very interesting. So, yeah, so it sounds like, this helps to kind of shore up our contention that we're dealing with, to my thinking, this fits with an AL amyloid. In that, if you were AA, for example, such as with, I don't know, familial Mediterranean fever, you're not dealing with antibody as the driving. That's not the protein that's abnormal. So this points in the direction of AL.
Okay. And it sounds like you would you still pursue a biopsy at this point? Or are you pretty convinced of the diagnosis just based on these?
Technically, if you want to render the diagnosis of amyloidosis, this is highly suggestive of the diagnosis, but does not give you it necessarily. So you do want to, if it's possible, try to ascertain through tissue. But I think we've got enough information to start to work with that. I think we also have to work up why this patient has elevated light chains.
What kind of things come to mind as far as that workup goes?
All right. So I'm just looking through and seeing what SPEP and UPEP look at, because I just kind of, my gaze
Right
is down
to the red.
because of the giant screen.
Absolutely.
So let's see. So the immunofix is on, that's urine immunofix?
It is, yes.
Okay. And nothing going on in the serum that we have picked up on. Okay, so it's being cleared pretty avidly. Okay, and that can happen. You can sometimes see that happen. So looks like our kappa is appropriately elevated. So my next thinking, now that you've looked at serum, my next thinking, especially in a patient who has elevated creatinine, you're going to be starting to think, how do I work this up? Thinking about imaging of the long bones, looking for other stigmata that might suggest myeloma or some other plasma cell dyscrasia.
Absolutely. And what other, organ involvement, if at all, are you concerned about?
Okay. For me, the organs that I tend to think of, kidney, obviously. GI tract is going to tend to be less common. Cardiac involvements can be quite common, and patients will often present with right-sided symptoms early on. Hepatic disease can occur with this. So it's kind of a matter of working that up. So, something like an EKG can be very helpful if you identify the combination of low voltages plus LVH can be suggesting infiltrative process.
Absolutely. Well, I'll go to imaging here. We have a CTA, which was actually done due to the bleeding and some delay in the endoscopy, actually, which at this point showed some blood contents in the stomach, but also showed some fibrofatty changes in the liver and enlargement of the spleen. They didn't show any other vascular abnormalities or active bleeding ongoing at this time.
Okay. So very interesting. Big spleen. And then you also have some changes in the liver that might be hard to place necessarily, although I wouldn't expect liver fibrosis. We just have to think about, could that be a red herring? Could that just be good old, MASLD and not hepatic involvement due to amyloid?
Absolutely.
And I don't know that a liver biopsy, I don't know that the folks that didn't want to do a fat pad are going to want to do a liver biopsy under the same circumstances.
Yeah, absolutely. Okay. Well, A little update. So the patient stabilizes, her INR improves. She actually decides to leave the hospital prior to biopsies being done due to needing to get to some family obligations. She actually is subsequently readmitted to the hospital for a biopsy and management of the coagulopathy to allow the biopsy to be done. So she came back, she got some vitamin K and FFP again, and they went ahead and did a bone marrow and a fat pad biopsy.
Excellent.
So
And the bone marrow may help you anyways, because sometimes on the bone marrow, you will see amyloid deposition as well. So even if you didn't get the fat pad, that's fine, but trying to ascertain that a certain organ is involved that is impaired is pathognomonic.
Absolutely. Okay, so we have a pathologist or a resident from the Department of Pathology, Dr. Julia Rockhole here, and she is going to go ahead and walk through the biopsy and the biopsy results for us.
Can you guys hear me okay?
Yeah.
All right. It says my sharing is not turned on. Requested some access to sharing.
I think we're working on getting you access. Sorry about that.
Okay. I think we're good now. Excellent. All right, so I take it you guys can see my screen now.
Yeah.
So first I'm going to start with the bone marrow biopsy that we have here. And then we'll follow up with flow cytometry that's on the same case. So here's a representative section of the bone marrow biopsy. Given her age, she's 39 years old, it's mildly hypercellular, but all the contents show maturing trilineage hematopoiesis. And given the history, you know, the nephrotic proteinuria and the free light chains and everything, you know, the concern for amyloid was here. And so we also looked at CD138, which highlights the plasma cells in particular, and the normal plasma cell amount that you would see in a bone marrow biopsy is less than 2%. And so the brown staining is the plasma cells on this. And so this was found to be about 10 to 15% plasma cells within the bone marrow biopsy. Moving on, we ordered the kappa and lambda-ish, which we can use to have the ratio. So it's kind of junky, but you can see like the purple areas are the plasma cells that highlighting kappa compared to the lambda cells. And there's like one in this focus that has the lambda staining. So it's definitely more kappa restricted in like a 5-to-1 ratio. And as you mentioned before, you can also check for amyloidosis on the bone marrow. We did Congo red, we did thioflavin S, and you can also use trichrome to identify amyloidosis. So the dark blue is the bone, and then the hematopoietic contents are the red, but this like lavender area that we see here is highlighting amyloid deposition. So this is even like a vessel here, and you can see that there's amyloid deposits within that vessel. So following up with the flow cytometry, the x-axis on the one on the left is looking at CD38 again, and the y-axis is side scatter. So in particular, we're looking for plasma cell populations here. And so everything in this gated box is representing plasma cells. And out of all of the cells present in the flow cytometry, it's about 2% of plasma cells. And then looking at your lambda versus your kappa, you can see that it's lower for kappa, but it's higher, or sorry, lower for lambda, but higher on kappa, which is this population again of plasma cells that we're following. All right, so this is the flow cytometry that was about 2% of the clonal plasma cell population. And this was the report for the bone marrow biopsy. So everything we mentioned before, mildly hypercellular maturing trilineage hematopoiesis and plasmacytosis, increased kappa lambda ratio up to 5-to-1, and then Congo red stain, and I showed you the trichrome staining was positive for amyloidosis. So that's what the comment below is commenting on. And then I don't know if you were going to get to this in your presentation, but she did have, oh, I'm sorry, I forgot about this slide. And so because we go further to type our amyloid, it was sent to Mayo Clinic and it was found to have NY light chain deposition, again, with the kappa subtype. And then this was I was going to talk about. You were talking about the stomach before. She ended up having a stomach biopsy in 2024. And so this is roughly what the normal portion of the stomach looks like. And this was on the same section. We can see that where the glands were before, there's this like pink deposits that are going on, interrupting those glands. Here's a higher look of this pink amorphous material. And so this also had Congo red staining, where you can kind of see that salmon pink presentation where those amorphous deposits were before. And using the Congo red polarization, you can see the apple green birefringence. And here's some more sections. She had a lot of amyloid deposition. It was very impressive in her stomach biopsy. And so it was signed out as just amyloidosis. And that's all I have. So if you have any questions, let me know.
That was great. Thank you so much. So Dr. Johnson hit the nail right on the head as far as the concern for amyloid. And just as far as kind of how this, the diagnosis here, as we've heard, is AL amyloid, causing coagulopathy from factor 10 deficiency, which Dr. Johnson mentioned. The amyloid protein itself can actually bind up the factor 10. And that's a lot of times the mechanism of the coagulopathy that can be caused here. And it also she had gastric involvement, thought to have hepatic and splenic involvement as well as the renal involvement, causing the glomerulonephropathy. As far as how she's done since, she has established with BMT in the meantime and started on chemotherapy regimen. She has had a hard to manage coagulopathy, and her INR is persistently in the 2s to 3s despite being treated with chemotherapy. She has remained off anticoagulation despite her clotting history because of this continued factor 10 deficiency that she's had. And I don't have much to add here because Dr. Johnson kind of taught us all these things off the cuff, but just AL amyloid, thinking of the most common organs involved typically is the kidneys, the heart, the GI tract, and the peripheral nervous system. So a lot of times causing a neuropathy here. The coagulopathy, like in our case, and like we just talked about, can be the proteins binding the factor level, but also can be caused by severe hepatic involvement, so decreased production of the clotting factors. Definitive diagnosis is always made on biopsy, but often can be seen in the immunofixation showing an increase in the serum free light chains. And treatment can be with stem cell transplant or with chemotherapy, but often the coagulopathy especially can be very hard to manage. And I thought you did a great job kind of tying together this patient in that she came in anticoagulated, bleeding, and then with a coagulopathy, but clearly something was going on in the stomach that predisposed her to that, and then tying that all together with the renal involvement of the abnormal amyloid protein, causing all of her organ dysfunction and putting it together. I also thought the interesting thing with the nephrotic range proteinuria is often it can cause coagulopathy and factor deficiencies because of the protein that's spilling, but it would be pretty abnormal in that case to see a specific factor deficiency. So
the other thing to think about in that context, sorry to interrupt, the other thing to think about in that context, of course, is spilling of the protein C and protein S in the urine, much like you would see with primary membranous GN, which is associated with higher risk of thrombosis. So it doesn't automatically mean you're spilling things and then being anticoagulated, so to speak, but it's actually a procoagulant. So yeah, in this case, knowing that it was factor 10 expressly and all by itself helps you think about this.
Absolutely. Well, thank you so much. That is all we have. If anyone has any questions, and then we have our CME credit here.